Welcome to State of the State. As part of our celebration of Mental Health Month, we're here today to talk with state leaders about current challenges and transformation underway related to children's mental health in Rhode Island. I'm Susan Orban, Director of the Washington County Coalition for Children, a regional advocacy group in Southern Rhode Island. And I am honored to be your host for today's show. Our guests today include Novais, Acting Secretary of the Executive Office of Health and Human Services for Rhode Island, otherwise known as EOHHS, and Marti Rosenberg, Director of Policy Planning and Research at EOHHS. Welcome to you both. Thank you for making the time to be here today and have this important discussion. Before we begin, Anna, would you mind explaining for our viewers what EOHHS does in a nutshell?
Absolutely, and thank you for having us. It's a pleasure to be here with you, Sue. I don't think there will be a better host who have a conversation around mental health than you. But so EOHHS is an umbrella organization in the state of Rhode Island that is responsible for all of the health and human services agencies. Basically, that includes the Department of Health, the Department of Human Services, the Department of Children, Youth and Families, DCYF, Behavioral Health, BHDDH, so Behavioral Health, Disabilities, Hospitals in the state of Rhode Island, includes the Office of Healthy Aging and Veterans Affairs. So basically 6 agencies, plus we are responsible for the Medicaid program. So you're talking about 42% of the state's budget when you're talking about all funds. We serve over 300,000 people under Medicaid right now, enrolled in Medicaid. And from a prevention perspective, you're talking about all state. So that's a little bit of what we do. And we coordinate and align policy, interventions, leverage resources, truly trying to create a comprehensive, not siloed system of health and human services in the state.
Well, thank you for that explanation. And it's clear that a number of the agencies that have responsibility for children's mental health fall under your umbrella.
And they do. From DCYF as our children welfare agency to the Department of Health with responsibility for early childhood development, to BHDDH, who has responsibility for substance use, and with Medicaid, who is responsible for coverage and paying for insurance. On a sense, healthy aging, it's another one, because how many children do we have that are being raised by grandparents? So that's another connection.
Right.
Or with veteran affairs. So all of them, but some a little more than other.
Well, we're honored to have you.
Thank you.
So there's no question that COVID-19 has exacerbated the challenges that youth face, but these issues have really been around for decades. And as I was preparing for today's session, I came across this op-ed that was written by Dr. Greg Fritz, who was a professor, he's now retired now, of child and adolescent psychiatry at Brown, who had medical appointments at both Bradley and Hasbro, dated from April 19, 2005. And the article's headline is U.S. Crisis in Child Mental Health. And the issues that he identified are some of the same issues, sadly, that we're experiencing today. And they include children boarding in emergency rooms, awaiting psychiatric hospitalization, the lack of children's services and enough of the types of services, and a shortage of children's mental health providers. So you fast forward today from then, and if we were to look at the longitudinal data about the rates of anxiety and depression and so forth, they've also been rising. Children, if you talk to them, they talk about the struggles that they face in trying to manage the many pressures of being a youth today, worrying about the academics, the family pressures, their social lives, and the impact of social media. I mean, let's face it, that is a real source of both positive and negative impact for our youth, with many youth struggling from bullying. And then you add to that the fear of school shootings and the regular practice of active shooter drills, and exposure to an ever-changing, unsafe world. And it's no wonder that our children are facing some of the challenges that they're facing. And it's not surprising that many refer to this generation as the lockdown generation after COVID. So this issue is complicated. And there's no silver bullet, and I don't have to tell you guys because you know better than anyone. So given all of that I just laid on this table that's sort of overflowing here.
Table right now.
Yes, yes. What brings you hope about taking on this important issue for our youth?
What brings me hope? Well, let's start with people like you who many years ago, I've known you I don't know how many years, fighting for children's mental health, continue to be at the table with the same passion and the same commitment. You are an example of many providers in our state. Brings me hope. My children, my grandchildren that I have right now, for whom we have an obligation, not just mine, but our collective children, to make this work. And we have an obligation to figure it out. You mentioned that this crisis is not new. I remember 30 years ago when I first started working as a clinician, we were talking about challenges of mental health system, mental health services for kids, how we didn't have a system of care in the state. We had services, different organizations providing scopes of services, but not a system of care in the state. That was 30 years ago. We had no cultural competent providers. One of my first trainings, when I barely speak English at the time, was to talk about cultural competency in family counseling therapy. And I remember being so afraid, not because of the lack of knowledge in the state, but my lack of English at the time. But fast forward, those are still some of the same challenges. Cultural competency, you talked about access, you talked about the ongoing or growing complexity of the issues. You talked about a lockdown generation, but it's also a generation that has been through a normalization of what used to be big crises and things that require big responses. School shootings became normalized in this culture, unfortunately. And until we regulate all of that side, that's going to continue to be anxiety producing in children also at the same time, those younger children who look at the news in the media. And so we need to come up with solutions that are also going to be equally complex to be able to respond to the complexity of the problem. And the same way we've had a long-lasting crisis, COVID exacerbated, COVID brought light to the crisis, but as you mentioned, 2005, or if I go back 1995, we were talking about some of these issues. So it's going to take commitment and staying power for those things to happen. And that's the other thing that brings me hope. I think we are at this unique moment in our state and in our nation where focus is on behavioral health and resources are being brought to behavioral health. And so if we don't change the system of care, if we don't get it right at this moment, then when are we going to be able to do that? We are doing everything we can to do that, and Marti can talk about some of the things in detail that we're doing, but we're bringing the administration, the providers, public-private partnerships to do what we all know needs to happen, from addressing workforce crisis to system of care to building blocks of that system. We are trying to truly transform that system once and for all.
Well, that's great. Well, let's unpack some of those transformative efforts you have underway. First of all, let's talk about this system of care that you talked about.
Yes.
So, like medical services, which are provided along a continuum of intensity from office visits to urgent care to emergency rooms and hospitalizations, then home care, behavioral health services are provided along a continuum too, known nationally as this system of care. I don't know who came up with that name because it doesn't have much meaning for most people, but for those of us that are in the field, that's what, that kind of transformation is what we're talking about. And so what does that system of care look like for children?
I'm going to let Marti give the details on that one because she's been passionately leading that work for EOHHS. And so, Marti, why don't you talk a little bit about what we've been doing?
So we started talking about the system of care and really investing in it in 2020. And you can remember what was going on in 2020. And we said, in the middle of this crisis, in the middle of this mess, what better time to talk about really bringing the system of care together? And the components of it start with prevention. We need to think about prevention. And then we need to think about crisis response. And so we call it, in the children's world, mobile response and stabilization services. It's not enough to go out to a family, to a child who's having a problem, and just be there for one night. And when we talk about mobile response, really it is a 24/7 endeavor. We have to have that stabilization service. So we have, through getting a grant from SAMHSA, the Federal Substance Abuse and Mental Health Authority, and dollars that we have invested through some home and community-based services, kicked off mobile response and stabilization in Rhode Island. We have two providers, Tides Family Service and Family Service of Rhode Island, and they are providing 24/7 care in this mobile response way. Unfortunately, it's a grant, so it's not to the whole state, but we're getting ready to expand it to the whole state soon, and we can talk about that.
How's it going?
It's going really well. It's going really well. We have served 214 cases as of last week, or the week before, and those children are, in general, not all of them, but in general, staying out of the emergency department, being able to go back to school. And the key to it is, it's not just that one mobile response in the middle of the night or after school. It's days after, it's at least 30 days of stabilization services. So child might need ongoing therapeutic care, or maybe they just need to get back to a provider who they had seen but aren't seeing now. And the program says, we're gonna respond, and then we're gonna get you situated so that you're in a better set of circumstances. You can get the care that you need ongoing. And that keeps kids out of the hospital. So that's the first part. Well, that's the second part, prevention and mobile response. The third part is expanding the service array that we have to treat our kids. And we have made some significant investments in our service array. The service array is connected to the Department of Children, Youth, and Families, but what we have done in this investment is to make it available to kids who are not in DCYF care.
Now that's something different.
That is something different. And so it has nothing to, it's not connected to DCYF. Families can feel confident that they can just go to get these services. They do not have to be connected to DCYF in any way. And so that's the next part. And what we really want to do is make sure that mobile crisis isn't, as we call it, a bridge to nowhere. If you get care, in a crisis situation, but then don't have another place where you can go for ongoing care, that mobile crisis is not going to really help you, because then you're going to get stuck in that crisis again, potentially. The fourth part is care management. And in Rhode Island, that is done with a program called Family Care Community Partnerships, or FCCPs. And these Family Care Community Partnerships are ongoing services for families who just need a little bit of help. They are, they're doing like okay, but as any family does at any time. Maybe they need a little bit of therapy to keep them together. Maybe they need a little bit of investment, like they need to move and they need a little bit of first month, last month payment. And sometimes this program can provide that, or just something has gone wrong and they need just a little bit of help, and then they'll get back into it. And then finally, we think about the much more intensive levels of care in residential care. And we hope that with the expanding what is in the beginning of that system, you go down and you need much less residential. And so we're really trying to keep kids out of the hospital, out of residential care, with their families, with services that they need, with supports that they need. And we've been able to make, over the last 2 years or so, and moving into next year, about, between all of it, $22 million worth of home and community-based investments, and then the SAMHSA grant that we got is another $10 million on top of that. And we were very much helped by both of our U.S. senators, both Senator Reid and Senator Whitehouse, to get more dollars for mobile crisis. That's almost another $1 million. So, as the Secretary said, people see the problem and they're willing to help and make the investments. And is it perfect yet? No, but it's getting there. It's really, we're getting to a place where we can see changes in the system.
Some movement is happening.
Yes.
That's fabulous. So, as you've embarked in this work related to system of care, I know that you've gotten a lot of feedback and input from various advocates like myself and service providers and so forth. One of the really important components, I believe, has been the input of families and youth in that process. Can you talk a little bit about that process and about how you see those voices guiding things in the future?
Well, I would start by saying something very quickly, that there are 3 guiding principles that we use in the work at EOHHS. It's voice, choice, and equity. And voice, because truly, as you mentioned, you cannot build systems for people without their input. And so when we listen to the voice of our providers, of our children that we serve, of the families that we serve, the communities where they live, that's a critical component of that process. And then if you listen to those voices, you are able to develop programs that offer choice, the services that folks need, at the place that they want them, at the time that they need them or want them. So that's building from voice, listening to the voice, and then creating choice. And then we do believe that if we do those 2 things, you are able to get to equity. So in the process that Marti can describe in more details, not only we heard from providers, but listening to those that we serve, the families that we serve, it's been important. Variety of ways that we have engaged with parents. For example, in the work that we're doing around substance use, we have a family task force, a sub-work group, because we wanted to make sure that we listen to the voices of the families. And so we are doing that across the board, and Marti can tell you more what she's doing with system of care.
As a part of the SAMHSA grant, it's exciting that they actually require us to have what's called a family engagement organization. And we are almost finished with the procurement of that agency. I can't quite say it yet because I'm not allowed to, but very soon we'll be announcing that. And we're going to have actually 2 staff people that we're going to add to our team whose sole job is to go out and talk to family members, recruit them to come talk with us. We also have a fantastic evaluator who's doing qualitative evaluation, focus groups, both on the family level and the provider level. It's precisely underlying what the Secretary said. We shouldn't be doing this work without the input from the people who are affected by it. One of my colleagues said, we'll know it's a system when the providers who are providing the services see that it's a system, and when the family members who are engaged in it see that it's a system. It's not our place to call it a system. It's their place to say, I know where to go, I know where, and one other component is really the getting to a single point of access, but with no wrong door. And so what that means is there's a place to call, one place that you can get to what you need, but there are so many doors to get you to that place. And so that sort of talks to the importance of getting family engagement.
No question about it. One of the other things that you mentioned earlier was the issue of workforce. So one of the things that has really been also brought to light is that the social service field and behavioral health field has been one historically that has been low paying. And so during COVID, the Great Recession really hit the field. And so not only do we not have enough providers before, but now we have even fewer providers to choose from. And so I know that you all have been working with DLT and others in the state to try to begin to address this issue, because behavioral health and social service agencies have been crying for help related to it. We can't service people, they say, if we don't have the staff to be able to do it. So can you talk about that a little bit?
Yes, we can. So I would approach it, there's three things that we are working on at the same time, in parallel, I would say. One, we made tremendous investments in terms of recruitment, retention, and training funds during these past 2 years in COVID, and still in this year, corporate fiscal year, trying to retain the workforce that we have, recruit new workforce, and for the ones as part of retainment, not only financial bonuses, incentives, and so forth, but also paying for tuition, paying for graduate studies, and so forth. So really focus on that, and particularly focus on the BIPOC community.
Yes.
So that's one component that we're doing. The second component, we have long-term, we've been engaged for the past year. We started in April of last year with a health and human service workforce strategic planning. So not workforce in general, but with a focus on health and human services. Working with the LT, post-secondary education. We've engaged, I don't know, over 400 folks from all areas, stakeholders again, providers, the workers themselves, the organizations, trying to understand what are the career pathways we need to come up with. How do we train, recruit early from high school people to come into the profession? How do we support the current workforce if they want to grow to outside of the low-paying jobs that you have? So there is all that effort, and Marti can give you some details, but there is a summit that we're going to have in May? June, where we're going to do 1 year later look at what we've learned and the pathway forward. And then the third one that I think it's important, because you mentioned payment, is that there is, last year the legislators did pass a new rate study bill that has directed OHHIC, the Office of the Health Insurance Commissioner, working with us in partnership with us to really assess and study all of the social health and human services, social services work and providers and lines of services, and do a study of the rates in Rhode Island. How does they compare with the rest of the nation, maybe Massachusetts, close by, New England, and when was the last time that they were touched? And so that's also underway. So that will be the third one that then will lead to rate reform later in probably 2025, but maybe you want to give some more details on workforce.
What I would say about it is that it is a whole of government approach. We're really, within the McKee administration, getting as much of the different entities as possible engaged. And again, it is, we're breaking down the silos. It is interagency, it is public and private, because we need that level of commitment to make it work. And there are some small things that can happen, and there's some large things that can happen. But what we need to do is that recruitment, that engaging people to say why you should come into this workforce is key. I mean, I think that's kind of a crucial beginning of it. We need to attract, we need to train, and then retain.
Mm-hmm. One of the things you mentioned earlier was the need for prevention. And how the payoff long term is something that many people within any given budget cycle or any given administration sees the payoff for. And so it takes real vision and long-term vision to be able to make commitments and stick with them related to prevention. And so can you talk a little bit about that and your thoughts and action plans related to prevention?
Let me talk about some of the work that we're doing in the substance use community and addressing overdose and opioids. We are thrilled to be recipients of opioid settlement dollars. through the settlements that happened all over the country, our Attorney General got us a significant amount of money, and EOHHS is responsible for spending and procuring that money along with our community engagement to tell us what we should do, and then our partners in state government, especially at the Behavioral Health Department, BHDDH, and the Department of Health. And we've been working very closely together. There are two specific proposals and projects within that work that bear talking about. One is school-based prevention, and we have funded Coastline, which is the Rhode Island Student Assistance Services. They've got counselors in every school, and this is one-on-one engagement with students and this larger prevention, sort of community-wide prevention services. And then recently, working with the Rhode Island Foundation, they helped us fund 8 grant programs for entities across the state in the community. And it was very important to the folks that we are working with, the Opioid Settlement Advisory Committee, which advises the Secretary, and then very important to the Secretary, that we make sure to do prevention in schools and out of schools. Not every kid is in a school. Sometimes the school-based won't work for them, but others it's perfect to do that in school. So that's 2 areas of prevention that we think are crucially important. And of course, this is prevention tied to opioid use and preventing drug use, but since so many folks who are using drugs in ways that they wish that they weren't, have co-occurring mental health issues.
Question. For
there's
youth,
just connection
yes,
all over.
For youth, there's so much self-medicating that happens,
absolutely.
And so they really can't be separated.
Right. And we need to worry about harm reduction. If a young person is using drugs and they are not ready to get into treatment, we need to make sure that they will stay safe. That they know that there's likely to be fentanyl too often in a pill that they might get from a friend or on and they need to have that too. So the prevention happens both to keep them safe and hopefully to get them into treatment as soon as they may want to get into treatment.
Absolutely. So the other thing I think that is just so vital is that there's a commitment beyond the grants. So many grants come and go in our state, and then programs come and go with them. And I just hope that there is that thinking and planning going on related to sustaining these efforts over time, because that will be the key to really addressing the crisis long term.
Oh, absolutely. I think if you go back to the question as you had asked us also to think through, when you do prevention and if you continue with the substance use, you're not just thinking about the prevention, the harm reduction, you also need to think long term in terms of recovery and staying in recovery. It is important that you think long term and you think sustainability, so you're not all the time starting new programs. So one of our principles with the settlement fund, for example, we invested for this first year. Now, in the second year, we're going to looking at what needs to be maintained, what needs to be sustained, and that's some of the investments that we're going to make. The opioid settlement funds, it's 18 years. But that's one example. In everything that we do statewide, although it closes in 1 year, you ought to be thinking long-term vision. And for me, the way to do that, when you ask me about what brings me hope, we need for us to be able to do right by our children. We need to become what we called a parent nation, a nation that also supports parents, supports family, so they can be there for their children. It
No
needs to
question
take all
about
of
it.
us.
I couldn't say it better myself. And I know that we're at time, and I hate to have to wrap this up, but that's the perfect way to end this session, really. One thing that I do want to do is to let people know that if you're concerned about a child and need some advice, you should contact KidsLink for triage and referral services at 1-855-543-5465. And if you or someone you know needs to connect with a crisis counselor for emotional support or services, you can contact 988 24/7, 365 days a year by chat, by phone. or by text. And so I thank you, ladies, so much for joining us this evening. It's been a great discussion.
Thank you so much for having